going to be discussing on pharmacokinetics, the ADME acronym, which is the absorption, distribution, metabolism, and excretion or element of the drug. I have made well-detailed videos, and you can check the link in the description for each of these given ADME parameter. Now, don't forget that pharmacokinetics is basically drug movement from the word pharmacon, which is drug, and the word kinetics, which means movement. So pharmacokinetics is the movement of drug through the course of the body. So it is what the body does to the drug. Now we're going to be looking at each of the given ADME parameters and the factors that affect them. The first one is absorption. Absorption is basically the process by which the drug moves from the site of administration directly into the systemic circulation or the bloodstream. Now, these are the factors that affect the absorption of the drug. Before that, we are going to be looking at the mechanism of transport by which the drug moves from the site of administration into the bloodstream, passing, of course, the lipid bilayer. There are actually four processes by which the drug undergo this means of transport. We have active diffusion, passive diffusion, or you can say active transport, passive transport, facilitated diffusion, and bulk transport. Now, passive diffusion basically is the movement of drug from higher concentration to lower concentration, and it is most common in small lipophilic drug. Active diffusion is the movement of this drug across different concentration gradients with the use of ATP, an energy-rich molecule. Facilitated diffusion is the movement of this drug across different concentration gradients by the use or by the help of a carrier protein. By the help of a carrier protein or a transport protein. Carrier or transport protein. By bulk transport, otherwise known as endocytosis, as you can see here, is the engulfing of large molecules of drug directly into the cell. Now, these are the properties that affect the absorption of the drug. We have the route of drug administration, the pH and drug physicochemical properties, the first pass effect, dosage form, blood flow, and surface area. Now, of course, we know that drugs are given through different routes. Drugs that are administered intravenously have greater rates of absorption than drugs administered through the passage of the respiratory system, that is drugs that are inhaled. Of course, drugs that are inhaled have further greater rates of absorption than drugs that are administered intramuscularly, of which it is greater than drugs that are administered orally. And the least drug is those that are administered topically with a slow rate of absorption. The pH of the drug also affects the rate of absorption, and it is concluded that drugs that are of weaker acidic or drug that are of weaker acid are better absorbed in environments that are slightly acidic or of weaker acid, right? Drugs that are basic in nature are better absorbed in environments that are of weaker. The pH and the drug physicochemical properties is also another factor that affect the rate of absorption of the drug. And you can watch my detailed video. I expatiate further on this. But it is concluded that drugs that are of weak base are better absorbed in weaker in basic environments, and drugs that are of weak acid are better absorbed in acidic environments. Now, of course, the first pass effect is the breakdown or the metabolizing of drugs before reaching the systemic circulation. Now, drug taken orally, they have high first pass effects, and therefore they are going to have low rate of absorption, unlike drugs that are given intravenously, which is 100% directly into the bloodstream. We have dosage form. It is of common sense that drugs that are in form of solutions or suspensions are faster absorbed than drugs that are in form of tablets or pills. And of course, the blood flow and surface area also influences the rate of absorption of a drug. The next PK parameter we are going to be looking at is the distribution. And the distribution basically is the movement of drug from the bloodstream to targeted site of action or targeted tissue site. It is the movement, the distribution of drug from the bloodstream or from the systemic circulation to the targeted tissue site. And one of the things that you need to consider is the volume of distribution. Now, the volume of distribution just shows how spread out the drug are. When the drug is taken into the bloodstream, or when the drug is present in the bloodstream unchanged, don't forget that the drug needs to be present in the bloodstream unchanged. So the volume of distribution shows how spread the drug is throughout the body. Or you can see pharmacologically that the volume of distribution is the volume of which the drug is compared to that is present in the plasma. That means VD is equal to the amount of drug over the peak plasma concentration. Now we have factors that affect the distribution of drugs. We have the ionization and molecular size, the plasma protein binding, we have the regional blood flow, we have the presence of specific tissue receptor. One of the things I'm going to talk about is the plasma protein binding. Drugs that flow freely in the bloodstream, they can be easily distributed to the targeted sites, unlike drugs that are bound to plasma proteins. Let's say this is the plasma proteins. We have drugs that are free. Free unbound drugs can easily be distributed. That is, they have high rate of distribution into the targeted sites of tissue and organs. While drugs that are bound drugs to plasma proteins such as albumin or alpha acid glycoprotein, I explained further in my video, are least distributed. The regional blood flow also affects the distribution of the blood, as organs that are well perfused, such as the brain, the heart, they have higher distribution, unlike organs that are not, well perfused. They have low blood flow, such as the peripheral muscles and the adipose tissue. Now, the presence of specific tissue receptors also affects the distribution of drug. Most times, when drug enters the targeted tissue, some receptors exist in the cell membrane or in the nuclear membrane that can spit the drug out. An example here we see is the P glycoprotein, as you can see in the case of different drug efflux mechanism, whereby the drug is going to be regurgitated out of the cell as a form of resistance. The next PK parameter we are going to be looking at is the metabolism, otherwise known as biotransformation. It is the conversion of drug, or you can say the altering of drug from polar to non-polar so it can be easily excreted, or from lipid soluble to water soluble so it can be easily excreted. And we are going to be looking at the metabolism of drug in two phases. We have the phase 1. Phase 1 have processes such as the oxidation, reduction, hydrolysis, and other forms of chemical metabolism. And we have the phase 2. Phase 2 have processes such as the glutathione addition, sulfation, acetylation, glucuronidation. We also have methylation and the likes. Now, what does phase 1 and phase 2 mean basically? Phase 1 basically is the introduction of a substance or the unmaxing of a functional group that already exists in the drug. Don't forget that the metabolism of the drug seeks to do four things. The first thing is the conversion of the drug from active to inactive. It can be easily excreted, or you can say from polar to non-polar, or from lipid soluble to water soluble. So it can be easily excreted by the kidney, or the conversion from of the drug to a toxic form in the case of, for example, methanol to formaldehyde, or the conversion of the drug from, of course, the inactivation of the drug as a whole. Inactivation of the drug as a whole. The, the metabolism of the drug seeks to undergo this possible process. Now, the phase 1 biotransformation or the phase 1 metabolism is basically the addition of a functional group or the unmaxing of a functional group already present in the drug by the process of oxidation, reduction, or hydrolysis. The phase 2 seeks to make the drug that have passed through phase 1 more polar so it can be easily excreted. So the phase 2, otherwise known as the conjugation phase, basically adds more molecule to the phase 1 metabolite of that particular drug so that it can be easily excreted. It can add a methyl group, which is the methylation reaction. It can add a glutathione group, which is the glutathione addition. It can add a sulfur group, an acetyl group, or glucuronidation group, or like that's a glucuronide molecule. So it can be easily excreted from the body. So the purpose of metabolism or biotransformation is to make the polar drug become non-polar so it can be easily excreted by the kidney. And there are factors that affect the metabolism of drugs. We have drugs and the genetic variation. So the drug itself most times um, can affect metabolism. Some drugs are CYP450, that's the metabolizing enzyme. Cytochrome P450 inducer, some drugs are cytochrome P450 inhibitors. I expanded further in my lecture on metabolism and factors affecting metabolism of drugs. You can see the description in, you can see the link in the description below. We also have genetic variation, whereby some metabolizing enzyme of drug might be, they might exist in different forms, which we refer to as drug polymorphism or genetic polymorphism. So they are polymorphs. They exist in different variants. This can make a patient either a fast metabolizer or a slow metabolizer of some drugs. Other factors that affect metabolism are the nutritional state of the patient. If the patient is on protein, it's on a protein deficient diet, can affect the state of the enzyme. Don't forget that enzymes are basically proteinous in nature. Dosage of the drug too can affect the metabolism of the drug. High dosage of drug can saturate the enzymes and of course can lead to toxicity. And the age of the patient can affect the metabolism of drug. As we can see, infants and elderly patients, they have their drug metabolizing enzyme in a reduced state. They are not so active, they are never very much active, and this can affect the metabolism of drugs. We are also going to be looking at the next phase, which is the excretion or elimination of the drug. And I am not going to go into details because this is more of a pharmacokinetics crash course, but you can check the link in the description below. I have all my series on PK and the factors affecting them. Now, the excretion of the drug basically is the removal or the elimination of the drug from the blood by the kidney to be excreted as urine. Most times it's excreted into the feces, most times into saliva or even sweat. Now, the formation of urine follows these three processes, and drugs can be influenced in these three processes. You can check my video for further description. And of course, this is the nephron, of which the nephron acts as a filtering tubules which process drug elimination or drug excretion. Now, I'm going to be looking at some PK terminologies, and I'm going to be brushing through these terminologies, even though I have made another detailed video explaining these terminologies. The elimination or half-life of the drug is basically the time taken for the drug to be reduced by half, or the time taken for the drug to be eliminated by half its original concentration in the bloodstream. We have the volume of distribution, or the apparent volume of distribution, where Vd is equals to the amount of drug over the plasma concentration. We have the clearance of the drug, which is the volume of blood that is cleared of a drug per unit time. Volume of blood cleared of a drug per unit time. We have the steady state. Now, the steady state basically is the condition or that state whereby the administration of the drug, so we have the drug intake balances out the elimination of the drug. So the drug intake balances out the drug outtake, or you can say elimination. And it takes about 4 to 5 half-life to reach the steady state of the drug. The next PK parameters is the maintenance dose and the loading dose. I'll explain the loading dose first. The loading dose basically is, think of it as that initial boost, or that initial dose that you need to give to a particular patient to attain a desired therapeutic level of the drug in the body. Let's say a patient is in an emergent state and you want to give a large dose of this drug to achieve a specific desired effect. We are going to give, let's say, 500 pints of IV's bag. This is the loading dose of drug. Now, the maintenance dose is that small, minute dose that you give over a long period of time to maintain the desired effects or to attain steady states. And that is all for the PK parameter ADME. I want you to look at this question and comment your answer below. A 60-year-old man was placed on medication that were used in lowering high blood pressure. He has been on medications for about 2 weeks since diagnosis. However, on a certain day, he had a major episode and was immediately hospitalized. After a series of examinations, it was discovered that he was a fast metabolizer of the antihypertensive drug prescribed, and the drug therapeutic level was very low. Using your own knowledge of pharmacokinetics, using your own knowledge of ADME, what do you think happened? You can comment your answer below, and I would like to see you try. If you found this video helpful, don't forget to like, share, and subscribe. And don't forget to click on the description to go into further details and further breakdown of pharmacokinetics, ADME parameters, and the individual factors affecting them.